70% of patients with IBS have some underlying SIBO. And I wonder to myself, is it a chicken egg situation? Which comes first? Do you get SIBO first and that, if that lasts for too long, do you get IBS? Because we know people with SIBO in their gut microbiome have a reduced diversity. They have a decrease in beneficial bacteria, and they have an overgrowth of opportunistic species. I think any condition where someone right now is trying to use probiotics to restore the gut and it's not working, it's probably because you should be using FMT.
The question I always ask people is, if SIBO is purely caused by an overgrowth of bacteria in the small bowel, then why is it that when we do oral FMT, which is often done via oral capsules that would absolutely open up in the small bowel, why are all of the patients doing oral FMT not developing SIBO? Once you have a healthy gut microbiome, it should be able to self-manage, assuming you don't disrupt it significantly with antibiotics or long-term high-carb junk foods that really damage the health of the gut microbiome, and so on and so forth.
Welcome to Biome Breakthroughs. I am so excited to get to touch on this topic, and someone actually sent in a request to talk about this, so I'm pretty excited that someone's watching and really excited to hear about a specific topic, and today's topic is SIBO, or small intestinal bacterial overgrowth. And first, I just want to kind of lay the groundwork about what SIBO actually is, and then let's dive into, why are we talking about it and where does it fit for FMT? So SIBO is basically characterized as an overgrowth of bacteria in the small intestine. It is often correlated with irritable bowel syndrome, or IBS, with about 78% of people with SIBO having IBS or some traits of IBS.
And I think that's an important one, because people were often just lumped into the category of IBS. Like, it's a great umbrella that covers everything from constipation to diarrhea to abdominal cramping, bloating, you name the digestive disturbance. If it wasn't Crohn's or ulcerative colitis or some acute thing like a pancreatitis or something, it was IBS, nervous digestion, IBS, like everything came under that banner. And I think we're realizing more and more that it's just the banner's too big. And there's subcategories within it. And they've broken it down to IBS-C, IBS-D, as in like diarrhea or constipation. But it's turning out that more people that are lumped in the IBS category might actually have SIBO as one of the core contributors to their GI digestive symptoms.
And the symptoms kind of stack as, bloating, abdominal pain, gas, diarrhea, constipation, which is one of those things about GI disorders, which is you can have diarrhea or constipation, which I find they seem to be on the opposite ends of the spectrum, but here we are. But as well, fatigue, brain fog, and nutrient deficiencies. So sometimes I think we think about people having IBS or having SIBO and kind of just being like part of life. The idea here is it has really big consequences and can be, devastating to quality of life. We know that SIBO is often misdiagnosed or initially diagnosed as IBS. So I think we're seeing kind of more practitioners now kind of noticing that there are some overlaps, but there are some distinctive differences, as well as kind of allowing for testing of SIBO through the breast test, allowing kind of, I think, higher ability to easily diagnose it and treat that difference.
And I don't know when
overlap. So that's part of my confusion. Sometimes 70% of patients with IBS have some underlying SIBO. And I wonder to myself, is it a chicken egg situation? Which comes first? Do you get SIBO first and that, if that lasts for too long, do you get IBS? If you have IBS, can that lead to, the SIBO issue? Or are they independent and they just seem to kind of overlap? I don't know.
Yeah. And I mean, it's a relatively modern diagnosis. Like, this whole concept is really not all that old. I first began, treating patients pretty aggressively with the IBS SIBO in 2016, 17, and from the years following, treated hundreds of people with IBS and SIBO. My practice was very niche around digestive health, and that ultimately led to the creation of Novel Biome, which is an FMT provider. And so, we can get into that story a little later. But the reality is that this is fairly new, and there's a lot of doctors who are not up to speed on it. And so that's why we're here, to create a message and start to inform people. It used to be that from a diagnosis standpoint, it would be done through, and it's still, I don't know if it's still considered the gold standard, but I know up until very recently it had been, as far as doing an endoscopy. So going in and actually taking a biopsy from the small bowels, taking some bacterial content and then analyzing that to see, are there an excess of hydrogen producing or methane producing or even hydrogen sulfide producing bacteria. And that, thankfully is not the standard anymore. Now, more and more doctors, clinics, hospitals are relying on the breath test. But even that has a lot of limitations where, it needs to be done appropriately. You need the right substrates to get and identify the right bacteria. But ultimately, the way that it works is you drink a substrate. So you do some form of a fast and different tests of different requirements. But then you drink the sugary substrate. And then the bacteria will eat and ferment that sugary substance. And if there's too much production of gas, you'll then see that on the breath test. So every 20 minutes, you're blowing into a tube, which is sealed, and you're doing that every 20 minutes for 2, ideally 3 hours. You're then submitting all of those samples to a lab who then look at the concentrations or levels of gas produced by, through those 20-minute cycles. And it's normal to get a spike once the sample should, in theory, hit the large bowel. But if you're getting too much of a spike early, that means there's a likely overgrowth. Now, there can be an overgrowth of hydrogen-producing bacteria, which is more likely to lead to diarrhea, or there can be an overgrowth of the methane-producing bacteria, which is more likely to cause and result in constipation. So often those are there. And then there's a more recent category, which is hydrogen sulfide-producing bacteria. And that's hadn't been on the test for many years. I know there are some companies now, some hospitals testing for that. And that's a harder to treat one for sure. So hydrogen sulfide often results in people will describe it as like a rotten egg odor. And that could be through the gas, through, breath, other things. So obviously tough from a quality of life standpoint. But yeah, that's typically how it's diagnosed. And then the treatment would then, the conventional approach to treatment would typically keep in mind, is this a hydrogen? Is this a methane? Is this a hydrogen sulfide? Or is it a combo of all of them?
And then, one of the things about this, and we see it in IBS and we see it in SIBO, is that a lot of these treatments fail. Either they don't work or the recurrence rates are really high. And when we say really high, I'm saying way over 50%. We're sitting in that 65, 75% of people are showing recurrence of SIBO. And so one of the questions, and leads us to kind of talking about the microbiome, is one of the reasons these methods fail is they're not addressing the root microbial imbalance. Because we know that people with SIBO in their gut microbiome have a reduced diversity, they have a decrease in beneficial bacteria, and they have an overgrowth of opportunistic species. And most of this, specifically in SIBO, is looking at the small intestine, but it would be, I think, interesting to kind of understand how much of that you're also seeing an overgrowth of opportunistic in the colon as well, because you're seeing the reduced diversity in the switch in the profile across the gut microbiome. And I think sometimes we like to separate the small from the large, but that's all part of the microbiome, right? That whole system is there. And I think they are very connected. And by that, I mean they are connected. And so I think we want to separate. And I feel like that's a very old but traditional thought in medicine, is that every piece has to be independent and we should look at them separately. And I think there's no better way to look at that than an organ that is connected, literally connected together, and we want to look at them as two separate units, which seems crazy because they are attached.
Yeah, especially when you physically connect them. You could
the
gut and the brain, they don't have an obvious physical connection, yet those are also connected. And that's a very important thing. I mean, if you'd ask most even healthcare providers, where is the microbiome housed? They'll their first immediate obvious response would be in the large intestine. And from a count perspective, like a total amount of them, yes, you could make that argument, but the microbiome is in and on us. It's everywhere. Every organ system, every crevice, everything has its own microbiome. Your ears have their own microbiome. Your mouth, everything has a microbiome. And so, yes, by quantity, the large microbiome is responsible for a big portion of the total count of bacterial cells and other things within the microbiome. But there's still a huge proportion of this in the small intestine, and they have a real responsibility for the outcomes. The issue is when we start to create an imbalance. And my, hypothesis on the recurrence rates, I think you're totally accurate in that we're treating this the wrong way. We're not understanding what's the cause of this. And for some people, it is they're lacking the nervous system input to push the bowel through. The bowel is sort of like, you could imagine, like flat. They like pulse to move food along and also push bacteria along into the, from the stomach to the small to the large. And then, you have a bowel movement. The issue becomes, for some people, they create almost an autoimmune reaction in response to food poisoning. And so that autoimmune reaction goes against the neurological tissue that innervate the gut. And it slows these contractile forces and doesn't allow for the push or movement of microbes from the small to the large. But there's still supposed to be bacteria in the small intestine. And so if, the question I always ask people is, if SIBO is purely caused by an overgrowth of bacteria in the small bowel, then why is it that when we do oral FMT, which is often done via oral capsules that would absolutely open up in the small bowel, why are all of the patients doing oral FMT not developing SIBO? Right? Like, it's a bit of a paradox there. Like, it just doesn't make sense. If the cause of SIBO is an overgrowth of bacteria in the small intestine, then by putting a whole bunch, billions of bacteria in the small intestine, everybody should be getting SIBO. But that's not happening.
I was going to say, I think part of it as well is the disruption of the ability of the small bowel to do its job causes that lack of movement of bacteria out. So I think it's like the underlying issue is less about what bacteria is there and more about what allowed that bacteria to stay stagnant and overgrow.
Absolutely. And I think in large part, the imbalance or the dysbiosis that's in the small intestine is like a translation of what's happening in the large intestine. So you pointed it out, right? These patients are showing less diversity in their gut microbiome, more opportunistic, possibly pathogenic microbes within their microbiome. And so we are seeing a issue that starts in the large bowel and then translates into the small bowel. And from my practice, seeing tons and tons of patients, it really comes down to having an overgrowth or an imbalance following, significant microbiome disruption. So the more chronic, the more severe, the more times they've relapsed, the more history they've had of microbiome disruption, often overuse of antibiotics. So, there is this demographic that have food poisoning and they get it, and it's this autoimmune type response. But by and large, from what I've seen, it starts with a damage to the large bowel microbiome ecosystem that then over time translates into the small bowel. And that's where you get an overgrowth of these opportunistic methane producing, hydrogen producing bacteria, and the system can't self-regulate. And I think a part of preventing recurrence is treating what I believe to be one of the main, if not the root cause for the majority of SIBO patients is a dysbiosis in the large bowel. We need to get the large bowel balanced, have the appropriate amount of microbes. And that's where I think FMT, fecal microbiota transplants, come in and work really well. And I've seen that clinically, and we could talk about some of the approaches to how to incorporate FMT in a broader SIBO protocol to prevent recurrence.
Yeah. And so I think that's part of it is the more this happens, the further depleted the microbiome gets. The consistent treatment with antibiotics to deal with it also probably doesn't help. And with such high recurrence rates, and knowing those recurrence rates are tied to more disruption within the microbiome as a whole, looking at restoring the microbiome starts to make more sense. And I feel like some of the time with figuring out why FMT is being applied, because it's being applied in so many places across the board at such a quick rate, because it really works and it's a fascinating field to be part of. As someone who just thinks the science is really cool, when you start to peel back, what was the first thing? What was the first symptom? And I mean, in a case like SIBO or IBS or IBD, like we're dealing in the gut. So like restoring the gut it logically makes sense. But SIBO is different because the focus has been on the small intestine, and people do want to separate them and think about the gut microbiome only being in the large. And that's, as you talked about, not the case. But when we go back through what's happening with treatment and what's happening between recurrence 1 and 2 and 3 and 4. And when we realize that the dysbiosis within the gut as a whole is getting worse over those recurrence rates, looking at, can we go back and press rewind on this and restore that and see if that stops the problem? And I think that's logically where the use of fecal microbiota transplantation kind of came in. First, I think any condition where someone right now is trying to use probiotics to restore the gut and it's not working, it's probably because you should be using FMT. And we see this across the board in a lot of spaces. And when we're talking with healthcare professionals, we talk about the idea of, at some point, probiotics aren't responding. Some patients, they respond really well. It allows that bridge from point A disruption to point B. Probiotics are enough to kind of reduce the barrier that the gut is facing and allows them to kind of cross over to getting better. And then there's a group of patients who just don't. Part of this could be because probiotics don't engraft. They are helpful while they are there and they are gone when they are not. And for some people, there's no bridging. There's nothing there to bridge from. We're going from nothing to nothing. And putting probiotics in, you're not getting the response they expect to see because there's nothing they're helping along with, because there's nothing to kind of build or recover from, because the gut microbiome is toast. She's got not enough to grow from. And so that's where FMT comes in. The idea here is, okay, so we need to start fresh and build, and then allow the gut to do the job it was supposed to do. And by doing FMT, you're giving a healthy instruction manual. It's giving the IKEA instructions on how to build a gut microbiome with beautiful pictures and step-by-steps. But the idea here is it's re-educating the gut, allowing engraftment to happen and to make a healthy gut. And so when we're in the context of SIBO, the idea of restoring microbial diversity, which we know is gone, helping to colonize with a normal subset. So you're not seeing an overgrowth of pathogenic bacteria. You're kind of rebalancing the ecosystem. And then it's going to help with immune tolerance. It's going to help with gut mobility through the gut-brain axis, then sending the right signals in, as well as restoring some of the damage that has happened to the gut. For me, as soon as I hear one of the symptoms being fatigue or brain fog, I know we're now past the point of this is just a GI symptom to this is more systemic or systematic, because fatigue and brain fog aren't driven solely by the gut, right? That's some reaction of other systems working with the gut. And so I think that plays a big role of this idea of like, okay, so we need to start back at the beginning and rebuild so that the system can work properly.
Yeah, and one thing that we didn't mention, but what often happens with SIBO patients is they're instructed first to remove the foods that are aggravating to them. What are those foods? Fibers. And so I've seen patients, at the worst, literally only being able to eat a carnivore diet that was blended, literally like blending meat. It's the only thing they could digest and get away with without having miserable symptoms. So the longer that patients are dealing with SIBO, generally the more restrictive their diets become. And the low FODMAP diet is literally that. You're removing fibers. The FODMAPs are all, fructo, oligo, di, mono. They're all the disaccharides. They're the fiber that your microbiome needs to have diversity. So the longer you're on a restrictive diet, the more your diversity is going to continue to crumble. And again, the more times you've had this, the more times you relapse. And it's just this self-fulfilling negative spiral, unfortunately. And then, of course, the treatment, when you're going and doing this, whether it's an herbal antimicrobial approach or a prescription pharmaceutical antibiotic approach, are also damaging further to the gut microbiome. So you start off with a damaged, unhealthy gut microbiome, and it just gets worse and worse and worse and worse. And that's where some people are just like in this chronic loop of relapsing. And so the real opportunity is to bust the cycle by putting in an appropriate balance of the right microbes, and then slowly expanding your diet to include more of these foods that you would have otherwise been trained to think are problematic for you, but are actually the solution to helping you get out of this mess long term. And so that's the way that we really need to be concerned about these really restrictive diets. For a short term, that there's a lot of great benefits from being, on these restrictive diets, whether it's SIBO or whether it's any of these diseases, like just reducing the complication and variables. A lot of people will see short-term benefits. The issue comes long-term. How are we going to respond when we're always on a very restrictive diet, especially in the context of a healthy microbiome? Not enough fiber is a key issue. It's a problem. It's why we get a continually degraded microbiome.
Do you, completely unrelated to SIBO, but sort of related to this current thing, do you see, as from your perspective, as soon as fiber really starts to become an issue in your diet, that's a white or a red flag? I don't know which one. White flag is giving up, right? Of your gut. So as soon as you go like, I just can't eat fiber. If I eat fiber, like I'm out for a couple of days or my body feels, is that a good indicator that there's probably something
absolutely
in the diet?
Yeah, I mean, that would be an earlier sign, like something's wrong here. Now, I mean, if you eat a whole bunch of beans or something, like that's, you have some extra gas or like that's going to be normal. That's the body's normal response to that. So that to me wouldn't be an indicator. But if you have fibers and you just feel really sluggish and slow and, you're having brain fog or those types of issues, yeah, I mean, that would be to me a real early sign, along with any real ongoing recurring abdominal symptoms. That this is a key early indicator. And we're seeing that a lot, right? Like a lot of these now chronic diseases are, the history includes early digestive symptoms. That's what they're experiencing. That's what they're, going through. And so, yeah, no, totally.
Yeah. When we say, there are things we say sometimes, like we've said this before, and I feel like I start to see this kind of consistent pattern of we talk about how important fiber is, but then we also talk about how people, as soon as they have GI systems, was some of the first recommendations are to pull how much fiber they're having. And, fiber seems to play a role all throughout. So I think it's a good thing to kind of think about, like, where is fiber playing a role early on? And we know fiber is so important, and it's part of doing FMT. This idea is you do have to rebuild the diet because the diet feeds the microbes. So the more restrictive the diet gets, the less diverse and changes in the composition of the bacteria in the gut are going to change, because that's all you're feeding. And we've talked about this before in diet. You eat high sugary foods, you eat high fat foods, that's what you're going to start craving. But the idea here is you really do have to eat across the spectrum so that you feed across the possible bacteria.
Absolutely.
And specifically in SIBO, what we're seeing and this space has gone forward faster. It's similar to what we're seeing kind of in ulcerative colitis and Crohn's. We're seeing a good amount of kind of these controlled clinical trials. So, this is the pinnacle of what you're looking for when you're looking on a research perspective. And consistently in this space, improved GI symptoms, changes in the diversity of the gut, normalizing of the breath test, and right now, like everything, it's a second line or an adjunct treatment to antibiotics. But, part of this too is healing post the antibiotics. And so I think that plays a role. And in all of the studies, this is not the first treatment they're doing. So that, is important in context. But the recurrence rates are going to go down here, and you're seeing improvements in the symptoms, and you're seeing improvements in the tests used to tell you that SIBO is there. And the side effects tend to be, both in IBS and SIBO, they're mild, they're self-limiting, and they're focused in on GI symptoms that are going to self-resolve. And so the benefits of doing this when you're looking at what improvements you see, and there's secondary things here. So we get rid of the GI symptoms and we're helping with kind of the reading of overgrowth that we're seeing from the breath test, but restoring short-chain fatty acids, which is extremely important in terms of making neurotransmitters and basically the gut functioning correctly, helping with metabolism within the gut, helping with gut mobility, which are some of the more severe factors that are causing the SIBO long term. And that's where I think we're shifting out of those high recurrence rates by, like we said, dealing with that root issue. And another part of this, because, we're using capsules in a lot of cases in these SIBO studies, is if FMT was going to cause an overgrowth, then why would doing FMT get rid of the overgrowth? It's how does it work? But the idea here is restoring the balance across the whole thing. And so I think in terms of SIBO, there is some relationship between the small and the large colon that we have to appreciate. And, what came first before the SIBO symptoms? Did someone wake up with SIBO, or was there something happening before that? And as it increased and changed, then we get to the more severe side of things, which would be, a SIBO diagnosis.
Bingo. Yeah. And that's the beauty of a healthy, balanced microbiome is it'll self-manage. Right? Like that's the point of a forest. Like we're not going into a forest and like pruning trees and all of that. Like the forests are self-managed. They manage themselves. And sometimes even natural disasters are a part of the management. And the body has responses to deal with stuff like having diarrhea, or you had a vomit after eating something. Like that's the body's response to dealing with an issue. And so that's the great thing about once you have a healthy gut microbiome, it should be able to self-manage, assuming you don't disrupt it significantly with antibiotics or long-term high carb junk foods that really damage the health of the gut microbiome, and so on and so forth. So that's the great thing here. It's like we're not playing this loop-de-loop of trying to just keep killing our way to a balanced, healthy microbiome. And from a physician's perspective, and we've written protocols about this, so if you're a doctor, feel free, reach out. We'll share all of our resources. But from a protocol perspective, you can still do some antibiotics, antimicrobials to reduce the overgrowth of microbes. The key is that you're following it up with this root cause health response, which would be FMT, to rebuild the microbiome. But even in saying that, like not all SIBO patients need FMT. It's predominantly this is for the people that have not responded, and they've been years of dealing with chronic, relapsing, aggravating SIBO. And so, if it's just a moderate, occasional gas, bloating, like you could probably get away with a short course of rifaximin or some herbal antimicrobials, berberine, neem, garlic, what have you. That might work. But there's a whole segment of this population in which there's millions of people that are just not responding to that approach. And so something's wrong. And I think that's something for a significant majority, not all, but a lot of them, is this root underlying cause of a bacterial imbalance that is not being regrown, redeveloped, rezoned, so to speak. Like we need to rebuild that. And in part, it might be FMT. For a lot of these, it's also working to slowly expand the diet over time, right? We can't just get rid of this overgrowth and then not support the microbiome, even if it's not a super healthy one, by reintroducing these foods. But a lot of times people they're too afraid of reintroduction. And I get that. But it is an important part of recovering and rebalancing the gut. And in some of these people who that doesn't work with, you're sort of stratifying your approach, FMT is going to make a lot of sense.
Yeah. And it is. FMT is normally not, and it may not be in a lot of cases the first line therapy, because for some people they do respond, but a large proportion aren't, or are going to see a relapse of this. And so, thinking of it, is it an adjunct in conjunction with what you're traditionally doing? Is it an advanced approach for those who have not responded? But part of the beauty of FMT is allowing for maintenance and support while you're doing all of the other changes, so that when you're done the whole process, you're eating to a full diet. You're dealing with, we've dealt with the mobility issues, we've dealt with the inflammation, we've dealt with healing the gut lining when necessary. And now you go forward and keep feeding, keep fertilizing the garden you've just grown. And as always, part of looking at FMT and understanding the safety comes from donor selection, ensuring the quality of the product, understanding how to deliver FMT in each context is extremely important. And that's part of why we sit here and we talk about these things, why this makes sense, and understanding, why you have to be careful about the donors that are being used, and ensuring that they're well screened and that they are eating a healthy diet, that they are doing all the work to have a healthy gut. So not only infectious traits and not only conditions that could be transferred by the gut, but as well looking at that your donors are eating well and that your donors are exercising and living a lifestyle that allows for a healthy gut, because that's what you're putting in. And so the full understanding of not only infectious traits that donors are being screened for, but everything else is extremely important. And then making sure that, that it's being pharmaceutically manufactured, and that there are standards in place and that there is oversight, because that's why, that's how the drug system works. We want to make sure there are checks and balances to ensure safety, and understanding the patient and how this fits in. And so that's why we're here to answer questions and try to support you, because each patient is going to be a little bit different. And doctors know that if you're treating patients, they're not all cookie cutter humans, unfortunately. It would be much easier if they were, but that's part of it, right? So that's why we're here. We're talking about these things because as the research progresses, it's really important to have these discussions to go for that patient that as soon as you heard we were talking about that, you went, oh, I know this, or I've wondered why that person. This is why we have these conversations. And this is a fascinating topic. The next one will be fascinating because all of it is very cool and exciting. But if you're listening to this and wish, I wish they would talk about X, email us. This is why we're having this conversation. Someone said, I would love to learn more about that. And it allows us to support your questions and make sure we're talking about the topics that are most interesting to you. So, as per the end of every episode, I will see you next time. I don't know what we're going to talk about. Yeah. And I hope you email us and tell us what you want to hear about.
Yes. And if you are a physician healthcare provider and you have these patients that are struggling to get over this relapsing, remitting SIBO, these challenging GI cases, reach out to us. We'll share all of our resources, all of the studies, ideas or concepts for what you might do from a treatment perspective. We're really forthright in giving all of our knowledge, sharing all of our knowledge to better empower you. And if you're a patient who's struggling with relapsing SIBO, reach out to your healthcare provider, share with them this video, share our resources, and we'd be happy to connect with them as well.
Yeah. And as for always, we really appreciate you listening in and kind of hearing our rants about these topics. Follow along, subscribe, bells, buttons, emails, all of the interneting.
Do it all. It helps the algorithm. Give a thumbs up, give a subscribe. This will get the message out further and faster and help, unfortunately, the millions of people really struggling every day with some of these really debilitating symptoms in these more severe cases. So your support goes a long way in helping get our message out to the world.
Perfect. Thank you guys so much. And we'll see you next time.